Good morning. My name's James Stanger, and I'd like to do a video on using KPI tools to troubleshoot IVF performance. This video is a talk I was meant to present at the EmbMart meeting in Jaipur in early June in India, but for visa reasons, which the visa office refuses to give me a visa for being victimized, I probably will not be able to get there. So this video is to take my place. When I first suggested the topic, it was based on an article I wrote some years ago in the IVF book, troubleshooting in IVF labs. But in that time, I'm seeing KPI is not just a laboratory function, but a clinic-wide function that covers the following areas: laboratory, clinical data, quality data, and risk data. And it's the risk data which I think I'd like to finish up and make the most emphasis on. Standing joke, all clinic problems are a laboratory fault, and that just recognises that no one really understands what's going on. But I argue that once you use KPI to show that the exact opposite is true, that laboratory is functioning in a uniform and reliable manner that allows embryos to reach their full potential. And that's all it has to do. IVF these days is far more complex with new technology, client mix, staff turnover competency, and the sheer increasing intensity of workload, which didn't exist 10 or 15 years ago. But here are some primary truths. Female age is the only variable in IVF. 85% of all the embryos will never produce a live birth. One of the issues of ovarian hyperstimulation is that it generate large numbers of aneuploid embryos and lots of poor quality dud ones. The best pregnancy rate in the best group with the best euploid embryos is about 60%, but on average is about 35 to 40%, and that's being generous. Therefore, measuring pregnancy rates needs to be seen through this paradigm. By and large, IVF is about treating couples who have failed at conception, and the causes are widely variable, and they will all influence the KPI. But more recently, non-infertile couples are confusing the KPI performance models, creating significant issues with what the KPI data is actually reporting. Therefore, you need very careful KPI definitions. Now, I'd like to make the point IVF is not a car factory, and common quality management systems do not automatically apply. Consequently, the role of KPI management is really to separate the wheat from the chaff, to actually see through all the noise, variability, to have some very defined elements that should tell you, one, whether the lab is working correctly and where all the variability in the lab is coming from. Of course, if you if you go to the extra special interest group on KPIs, this is the list that they performed, and that's a reasonable one. ICSI damage, fertilization rate, cleavage rates, development rates, survival rates, implantation rates, and they are all really important. But I would argue that you should actually think a lot wider than that and look at it and look for KPIs to give you information about the dynamics of the lab, including the number of cases under 35, the number of ICSIs, the fertilization, the average A grade on day 3, the average A grade on day 5, the number of cases with at least one A grade embryo on day 3 or day 5, the number of embryos frozen, warm, number of euploid transfers, clinically, the number of women over 40, the number of women coming in for oocyte freezing, fertility preservation, the mix between fresh and frozen, but the cancellation rate, which I think is the important one, these were the subgroups of cancer due to hyperstimulation, failed fertilization, or no embryo or no transfer. This is something which no one ever reports on, but in fact, it's where you have it grow embryos and there are nothing to transfer. And looking where there's transfers, there's no transfer because they've all been frozen for genetic testing and aneuploid rates. I have got a section on clinical pregnancy rate per transfer, fresh and frozen, etc., miscarriages, but you can extend that to the number of single embryo transfers, and the clinical pregnancy rate per single euploid transfer for women under 35 is almost a benchmark. I have included some other ones like the live birth data, even though that may be collected 9 to 12 months later, but really you're looking at pre-eclampsia as an incidental risk which you need to monitor. But the more aspects you can apply the KPI to, which really does impact performance, and that includes, you can say, the pregnancy rate per transfer, which I'll discuss a bit later, but also the skills of the embryologist to identify embryos, etc., So there's one aspect is like with ICSI damage or cryopreservation damage, etc. But you can also use your EQA data, because I have one which I've heard of, which I'll talk about later. But looking at how many people are all agreeing or disagreeing with each other when they're making the assessments. Because in reality, if you have a KPI which is the number of A-grade blastocysts per pickup, that is all per very accountability, everyone to describe the embryo the same way. But you can also look at activity in different ways with the score, which I mentioned, and lastly, risks, which I'll finish up with. The primary problem is age in annual KPI management. And as you can see from the CDC data, the pregnancy rate per patient age, it just falls exponentially with time. But the interesting thing for this set of data is not the fall that we all know about, but the fall that doesn't happen when you use donor eggs. And that is almost a perfect KPI tool, except that not many clinics use a lot of donor eggs. But there's so many things that are changing dynamically that impact key performance indicators. One is the shift from fresh transfers to frozen transfers, and the shift from fresh eggs to donor eggs. And they will all have varying dynamics in KPI, which you need to be able to account for when you're doing your KPI tools. An example of this is a report from this group in Italy looking at workflows in the lab, but they used a KPI, and I thought this was a really good example whereby this is the number of blastocysts per mature oocyte collected or injected. But you can see this is the trend line where it just falls over time. You see the huge amount of variability because they're using percents with small number of cases. But theoretically, the KPI is actually constant up to 35. So as a KPI tool, it's not very good in its overall, but if you restrict it to women under 35, it's a very powerful KPI tool. So I'd just like to focus on that a little bit because I think that's one of the thrust of my talks. The perfect laboratory KPI is the number of A-grade blastocysts per cohort for women with 4 or more 2PNs and less than 36 years of age. Most KPIs, of course, are limited because of the impact of female age, but using a key KPI, which I talk quite a lot about and define in a talk coming up later in today, or later in the meeting, developing standard operating procedures, but using a key KPI tool confirms some degree of uniformity and detects true laboratory issues. A fewer cases that need to be managed differently or variably, but it's still important. But this goes to 40% blastocysts per egg, just reminds you that you're working at the very low end of the range. So any statistic you're going to have is inherently influenced by all the other noise affecting that 40%. But I'll also make a point that if you're really interested in quality in the culture system, then look at the best embryo, not the whole cohort. A few A-grade embryos will tell you that the system is okay. Let me just look at the value of the reference group in terms of I just want to do one graph. This is the fertilization rate, which over 2 years, you can say it's a brief decline. This is a Sherwood chart, looking at the actual value, 80% fertilization, and the Levi-Jennings chart just looking at variability, but both demonstrating that there is a fall in fertilization rate over time. But however, if you look at the reference group of women under 35, you'll see that there is no change over time, that this fall is a product of patient variability and not of laboratory conditions. You could spend an enormous amount of time trying to resolve this, and you won't resolve it because it's not a laboratory issue, it's a patient management issue. There is one drop here in September, which I'll put in, which is a transient drop and needs an incident form to be completed and to be investigated and report written to senior management of why. It may just be 2 or 3 cases. It may be actually one bad lot of media, for instance. But the key thing is return to normal. So it's an episodic thing, not a catastrophic consistent failure. And I also like to mention that you can use the new technologies of time-lapse and AI, even though I'm not necessarily a huge fan of AI. Time-lapse is really good, although every study has now shown it doesn't give you any more babies, nor does AI. None of these gives you any more pregnancies, but they're powerful tools in terms of monitoring the lab for KPIs, and I think you should take advantage of them, including for the score, for the AI score, the average score for women under 35, the average score for the top 3 embryos, the average score for the top embryos. But you could also have other ones looking at the nuclear fading, the time to the 8 cell, the time to blastocyst, just as markers of embryo quality. They'd be a lot harder to monitor, but if you do that for women under 35 as well, that is a really good benchmark. And I'd just like to make some last comments. Um, about 50% of all embryos will reach the blastocyst stage, and about 30% of blastocysts will be euploid. And there's a lot of data now. There's a lot of confusion about whether mosaics are now being called euploid or not. And you could have a whole shift in euploidy rate, which all because your laboratories now decided to call mosaics euploid. And so you've got to be careful there isn't an issue in the genetics lab. But now, of course, some aneuploid embryos can still give you live birth because the biopsy is testing trophectodome, and there is this concept of intercell mass preservation of viability and renewal. However, I'd like to make the point that healthy embryos are really quite robust and tolerate less than perfect conditions. And I can remember back to 82 when I started IVF, our culture conditions were pretty poor, but there are still cases with perfect 4 cells and 8 cells. So really healthy embryos are robust and can tolerate some diminution in culture conditions, but you may like to look at not the best ones, but the second or third best ones as a better harbinger of cultural change. I probably should have said that in the previous slide. So if one focuses on the healthiest embryos, then your KPI should reflect that they are present. Right? Having said that, I can actually see an argument for looking at the middle cohort as a far better test for culture conditions than the best ones. However, about 10% of all cycles do not have any good embryos at all due to issues to do with follicle recruitment, etc. And they don't reflect poor culture conditions. So I did some work 20 years ago on follicle vascularization, which no one cares about anymore. But in that study of 200 or 300 cycles, about 10% of women had lots of follicles growing, lots of embryos, but none of them came from vascularized follicles, and there were no pregnancies in that cohort of about 30 cases. There are some definitions, there are some problems with the definition on how staff describe the same embryos, and therefore KPIs monitoring things like blastocyst quality is subject to staff bias. Failure to see at least one good quality embryo in repeated cycles is a warning, but individually they just may be system noise. And the last point, which I spend some time, or I will talk about if you're at the meeting, the SOP for KPIs. I make a point that some KPIs should not be reviewed every month, but should be reviewed case by case. So some key KPIs, say fertilization rate or good embryo quality rate, should be monitored case by case by case in a dynamically evolving society. So every day, the senior scientist should review the KPIs for fertilization rate and put them into a graph and to make sure that they are within the variability. And so they are the first warning there's something may be wrong. But in my experience, the number of times you have a bad environment is very, very rare. Looking at clinical data, they're not interested in laboratory. And then you have to talk about it. A and B grade embryos, their eyes just glaze over. But if you go to the Maribar consensus, they're more interested in things like cancellation rate, hyperstimulation rate, oocyte maturity rate, complications of clinical multiple pregnancy rates, and your KPI. This must reflect that and must produce information that's relevant for them. So there's a whole swag of things which I've generated here, but when I've talked about them before, but I think it's really important to know what proportion of pickups per month are for IVF, for ICSI, for preservation, for oocyte freezing, etc. Your fresh and frozen mix, that has to mix all the time. Because if you're looking at the fresh CVT stuff and it's only being for cases where they're not going to genetic analysis, then that you're actually looking at a very poor subgroup. And so your KPIs for fresh ETs may well be very volatile and may not reflect the culture, just the fact that you have lots of poor quality cases. But the other interesting thing about caseload is the doctors will change how they recommend cases. They go through waves, IVF to ICSI, day 3, day 5 for PGT, etc. And all that has some impact on the laboratory. So looking at performance, if a doctor suddenly decides to do all his cases to genetic for PGT-A, then suddenly, and he operates on Monday or Tuesday, then you go to find on the weekend, you're suddenly very busy doing biopsies and vitrifications when you otherwise may not. So you need to have some way to monitor what's going on both during the week and over time. And this is a really good paper, really complicated. There's a lot of data in it, but it's a really good paper looking at how you can use KPIs to see what's going on and how to manage a workforce to accommodate that. And so this leads me into the third part, which is quality data, which is both looking at this section is on the most valuable and complex piece of equipment in the lab, your staff, their performance and their welfare. Staff burnout is a really important issue because that's where the errors occur. And in a court of law, you can't defend yourself if the scientists say, "Oh, I was just too busy." There's quite a few papers now coming out on burnout and look on the quality of the people doing the transfers, etc. So one way to do that is to generate a score per cycle and all the different techniques, allocate roughly the man hours required to do that, and then you can generate a KPIs that look at, say, the total score per month to see whether you're getting busy or not overall, and the staff per score per staff or full-time equivalents, and you get a graph that's something like this, which is the total score per month, which reflects the some perceived man-hour commitment to actual hands-on work, and you have a lower limit below which you may have too many staff, but you have an upper limit whereby you can go to your senior executive and say, "We are too busy. You're putting the clinic at risk. We need more staff." And this is just the staffing levels. You put more staff on, it falls, and then you put more staff on, it will fall again, etc. Another way is to look at their performance. So this I'm glad now. This is my third QAP site, which actually looks at how people can assess sperm and embryos, both pronuclear and blastocysts and oocytes or whatever. And you can do it in a standard way. So you can generate a single form which looks at the competency of all the staff over time, over 2 or 3 years, and all these different things. And you're looking for arrows that go up and down. These are Levi Jennings charts. And you're looking for um, arrows that go up and down here. In this case here, the pronuclear assessment, these people are definitely underscoring quality relative to everybody else. So you can look at a whole clinic over years. You can look at clinic in any 1 year, in a clinic in any 1 month performance. Blue is good, yellow is outside the normal range, and red is a bit of a warning. For any one scheme, there are 12 images each month. For any scheme, you look at performance per scheme, and any one scheme, you look at how individual scientists are recording it. But the bottom line is, unlike a lot of other QA schemes where you have one person does and send the result, and here you're testing everybody every month, albeit just using images. But you cannot identify if people are consistent or inconsistent with how they're scoring, and you go to any one person and look at their variability. But another interesting way to do it is, I think, is very clever. It came out just recently where you used AI to generate a anticipated pregnancy rate. So this paper approaches the question of staff technical competence in an interesting manner by using AI value of the transferred embryo to the actual pregnancy rate rather than comparing between staff. Nevertheless, there must be some approach to confirm all staff are performing in a similar rate, but this is a really clever way. But I think you should have some KPIs to measure staff performance in terms of activity, like the lysis rate, blastocyst survival rate, clinical pregnancy rates, and I make one here, clinical pregnancy per clinician times embryologist. I did a talk about 20 years ago looking at the differences in pregnancy rate between doctors and scientists because the doctor places the catheter and the scientist expels the embryo. So there's 2 parts of a transfer and you shouldn't do them independently. And lo and behold, of this quite complex array, there were 2 cases of combinations of doctor-scientist which had a really spectacular pregnancy rate, really above the average. But there were 3 other combinations of doctor-scientists which actually had very poor rates. And so I'd just like to put that in. But there are some KPIs that looking at performance and assessment skills and including oocyte damage, survival skills from freezing and thawing that you should consider. And lastly, in order to get in terms of time, I'd just like to talk briefly about risks. I now believe this is the most important thing of the KPI meeting. And if my talk, if nothing else, I think people should focus on the KPI risk KPIs in terms of performance. And there are 2 or 3 areas. One is the risk of pre-eclampsia, because so many transfers are now being done in HRT, FET cycles, where without a corpus luteum, the risk of pre-eclampsia doubles, and women are going to die from this if people aren't careful. So that's a real risk, and you need to be managing that. But that has to be done like 9 months later down the track. So this is a delayed KPI, but I think it's really important. But they're also looking at embryo mix-up and cryo-storage risks. If I was running a lab now, I'm 76, I haven't worked in a lab for 5, 6, 7 years, but if I was running a lab now, this is what I would start at this and work my way backwards. Witnessing is a priority because IVF is now so complicated that gametes and embryo errors are real. Not they weren't in the past, but they're real now. The problem is when error is identified, many staff will already have left and the paper trail will be cold. So you need to be generating for your senior executive a KPI risk section looking at witnessing errors and the amount of embryos in cryo storage. There's quite a few papers. I've actually done a talk on this in my YouTube channel, but this paper stood out from this. This is a group from Western Australia using a electronic witnessing system where they identified there were differences over time. The blue lines are where you put a dish into a scanned area with the wrong patient code, and the yellow one where you've done that but it contained an embryo. So this is just the wrong dish, but this is where you've actually made a mistake. So it doesn't mean the embryos were transferred. They were identified in the patient witnessing system, which you can review and create KPIs on. So there's a difference between time after 6 o'clock. It's a real problem. Everyone's tired. There's a lot of differences between staff. That's to do with training. But there's a lot of difference between individual techniques. And interestingly enough, oversight denuding was the one where there was the highest mix-up. I have no idea why, but it's quite evident that more mix-ups occurred there than anywhere else. It may be to do with the labelling of the cumulus complex dish, but you do need to have KPIs that at least record the percent mismatches and the critical mismatches. And I think if you're not doing that, then you need to get off your butt and do it because that's important. And the last one I think is an existential risk, which is the growing number of embryos and oocytes being put into long-term storage and never used. So I think you do need, the senior executive does need to have a handle on how many embryos and oocytes in cryo storage, how many have been there for a long period of time, and how many clients have embryos in storage over short term and long term. One of the really scary things is there's a large number of cases where women never return for surplus embryos, but if you throw them out, they are an existential risk. And the other one is women having their oocytes frozen. Only about 7 or 8% of women ever return to have those oocytes used. But if you damage them in some way or can't record them, they are an existential risk because you've actually taken away someone's potential fertility. And you need to have a handle on that. So one of the recommendations in this talk is you do have to have 1 or 2 key KPIs, which are keeping some track of what's going on in storage. That's a really scary thing. And I think it's getting worse at an exponential rate. So it involves long-term storage, labeling and auditing, storage of both euploid and euploid embryos together, traceability and old documentation and lost staff. It's a very long-term risk. And if you're the CEO of a company now, of IVF clinic, you don't know what accidents have happened 15 years ago, but you're liable. So just to finish, and hopefully I'm almost in time, an IVF clinic I recognise as a very complex operation with one clear objective over all others: the assistance of clients to achieve a viable offspring. From the laboratory perspective, it is to allow each embryo to achieve its innate potential, even if it's failure. Most clinics do this very well, and hence here are the KPIs to prove it. It's not a joke. Given, though, the potential to achieve a pregnancy is infinitely variable between all clients, variable dynamics in how clinicians elect to achieve this, the physical aspects of in vitro culture, and the legal infrastructure around the process, gaining a uniformity in productivity is really challenging, but your KPI tools should provide a tool to measure your success. There are other aspects where KPI can assist, and these include ensuring errors are minimised and litigation or adverse findings are avoided. At the end, KPIs are a tool to keep everyone informed, and they speak from the same hymn book and are aware of what the clinic is doing and to keep the staff and clients happy. So my rules for KPI management: create a minimum set of KPIs that are agreed to by the executive, calculate and present to the team at agreed intervals, review your KPI list annually for relevance, keep the KPI list to a manageable size. You can do a whole lot of other stuff on the side if you wish, but this should be a core stuff, and I've talked about that in my SOP talk. But always create a reference data set for your healthiest group that will allow you to differentiate between client treatment variation and culture variation. and view the KPI list not as a laboratory list, but a clinic-wide list. I'd like to thank you for this listen to talk. If you look at the video, I apologize I'm not there. Blame the Indian visa office. But I'd like to thank you for your time, and I hope this talk has been of value. Thank you.